Good afternoon, and thank you, Dr. Manoj Chawla and Dr. Purvi Chawla, and the DRS team for inviting me. We have a topic OHA combination, and we need to look at the good, bad, and ugly aspect of these combinations. So, we all are aware that it is a chronic metabolic disorder characterized by the insulin resistance, progressive beta cell dysfunction, leading to hyperglycemia. The reason is that this is only going to increase the risk of micro and macrovascular complications. So whatever we do, it has to be a comprehensive management as a management tool while managing people living with diabetes. And we are also aware of what are the oral hypoglycemic agents. They can be broadly classified into sensitizers, secretagogues, incretin-based therapies, glucose excretion enhancers. So you have a whole basket now available. Each class definitely works through distinct mechanism. So we have a combination among these classes. So one should be aware of the fact the combinations should have a synergistic action with less of side effects. So why and what is the importance of combination therapy? One thing is for sure, monotherapy is often insufficient for long-term glycemic control due to the progressive nature of type 2 diabetes. There is a progressive beta cell dysfunction, approximately 4% annual decline, worsening insulin resistance with age and weight gain, and development of adaptive mechanism limited drug therapy. So these are the reasons why probably the monotherapy is not going to suffice. So we need a combination therapy to target the multiple pathophysiological mechanism or defects lying with type 2 diabetes, thus improving the glycemic control. The recommenders across the globe had clearly said combination therapy is recommended if the HbA1c is above 1.5% of the target. So early combination therapy should be used if it's not in targets. Now we are going to discuss the good, bad, and ugly of the combination. Let's look at the good part of the combinations. One thing is for sure, it leads to about 1 to 2% of HbA1c reduction when you have an effective dual combination therapy. Along with that, almost the patients who can reach the HbA1c is about 60% vis-a-vis the 45% with monotherapy. Now, there is a reduced risk as well of the treatment failure with the combination than monotherapy, up to that strength of about 39%. Now we have a trial, verified trial. You all are aware of the fact that when they used the early combination of vildagliptin and metformin, what they did was a delayed treatment failure by about 2.4 years compared to the sequential monotherapy. So a fixed dose combination or an early combination may work better than the sequential increase which we do in most of the patients. Rather, that was the norm. So therefore, it demonstrates the legacy effect of combination therapy because the earlier you achieve the glycemic target, the effect remains for a longer period of time. Next is when you have a better glycemic control, what you do is you reduce the complications. And this is the age-old UKPDA studies which have taught us that the microvascular benefit along with the macrovascular benefits can be achieved if we have early glycemic targets which are achieved. So every 1% reduction of HbA1c can lead to 37% reduction in the microvascular combination, 21% reduction in deaths related to diabetes, and 14% reduction in myocardial infarctions. Now, if you look at the individual component of this combination, they have their own benefits as well. So just look at the SGLT2 inhibitors. They can be having 26% reduction in heart failure hospitalization, 40% reduction in renal disease progression, and significant reduction in CV-related death in the high-risk patients. Similarly, the GLP-1 receptor agonists, we have enough studies nowadays discussing day in and day out, probably every weekends, which have clearly shown there is at least 14% reduction in the MACE criteria and 22% reduction in the CV death. So These individual molecule in the combination, they can have a positive impact, and that is a good about the combination therapy. Now let's look at the common beneficial combination which you can have. We have an age-old combination metformin and sulfonylurea, and most prescribed, I would say, presently in India. Here, it is a cost effective, which is important. It's the amount of HbA1 reduction, which is extremely substantial rather, and that is important. But there could be a chance of hypoglycemic risk. They have a fixed dose combination as well. Now look at the metformin and SGLT2 inhibitors. Even they have a HbA1 reduction of about 1.3 to 1.8%. But along with that, you have the weight loss positivity, BP reduction, and cardiorenal protection. So you have an added benefit for these combinations, and they are also again available as a fixed dose combinations. Now the third one is the metformin and dapagliflozin. Again, the weight HbA1c reduction is similar, weight neutral it could be, but low glycemic risk. So each one has a potential to be introduced in a appropriate patient. That's very important. Again, they are available as a FDC. Now, the novel approach which we have seen for last few years is the DPP4 SGL2 combination. Now, they can actually target most of the pathways or pathogenetic pathophysiology defects in type 2 diabetes, and the reduction of HbA1c can be tune of 1.5 to 1.9%. So most of them can reach to the targets. Along with there is a weight benefit, and they again are available in the FDCs. So this is particularly benefit in patients with established CVD or high CV risk with moderate hyperglycemia up to 7.5 to 9%. So next is now what we have in India is a triple combination, triple therapy combination which are available. Now you have metformin, your DPP4 with SGL2, metformin, sulfonylurea DPP4, metformin, pioglitazone DPP4. One need to understand again, some of them have the benefits and concerns as well. If you look at metformin, DPP4, SGL2 inhibitors, the benefits definitely you have a minimum hypoglycemia, you have a the weight loss as well as potential cardiorenal protection. But if you look at metformin, sulfonylurea, DPP4 combination, it is cost effective definitely and a good robust glycemic control. But there could be some concern with the weight, the hypoglycemic risk and potential weight gain. And if you look at metformin, pioglitazone, DPP4, the only concern you need to choose your patients properly. So the concerns are definitely edema, weight gain, heart failure risk with pioglitazone part of the combination. So if you choose the appropriate patient, like those who have insulin resistance, then probably this combination will work. So in India, triple therapy is initiated when dual therapy doesn't work or doesn't achieve the target within 3 to 6 months, or when the HbA1c more than 10%. Now let's come to the bad aspect of the combinations. Now, one major problems obviously is concern is the hypoglycemia, and their particular of importance is that categories of population, be it elderly, renal impairment, history of severe hypoglycemia, hypoglycemic unawareness, long duration diabetes, or multiple comorbidities. If you have these features, you should be a little concerned about the combination which you are giving, whether the combination need to be given, or the oral hypoglycemic agent need to be given, a combination of those. So what does Indian guidelines recommend? Indian guidelines recommend avoid sulfonylurea based combination elderly patients and those with irregular meal patterns, which is very, very common because we have this tendency of religious fasting very commonly practiced in India. So you should be aware of those. It might work in the younger population, but usually in elderly population, you might end up with serious concerns. Now, the next one is the individual component of this combination, which can lead to serious gastrointestinal side effects. So you have metformin, you have GLP-1 receptor, you have alpha glucosidase inhibitors. All these are available in various combinations. So you need to understand this can multiply. It can have an incremental effects as far as gastrointestinal side effect is concerned. So one should understand how to actually initiate this drug. You should go slow, up titrate, take an extended release formulation, which might work as in case of metformin. And then at times, like in GLP-1 receptor agonist, small frequent meals can help you out. Adequate hydration is also important, and you might have to eat a proton pump inhibitors along with that as well. So GI side effects significantly impact the medical adherence, with studies in Indian population showing that 15 to 25% discontinuation are basically due to the GI side effects. So one should be aware of that as well. Third is obviously the weight gain with certain drugs. So when you are trying to combine, and if you have two drugs which are basically known to cause weight gain, probably that may not work in some population, because weight gain is particularly concerning with the Indian population who have thin fat phenotype with higher visceral obesity at a lower BMI compared to the Western or Caucasian population. So one should also be concerned, particularly with thiazolidine, sulfonylurea combined together. We have combination of that as well. So their weight gain can further exacerbate the insulin resistance and thereby worsen the glycemic control and can lead to increased complications associated with diabetes. Now let's look into the other bad aspect, which is very common: drug interaction and contraindication of the individual component of those combinations. So look at the metformin consideration. Drug interactions can be huge with cimetidine, alcohol, etc. Caution in India because there is a high prevalence of chronic kidney disease and vitamin B12 deficiency. Thiazolidine, obviously, if you have undiagnosed heart failure, you should be aware of the fact, and it's contraindicated by NYHA class 3, 4 and active liver disease. If you look at SGLT consideration, loop diuretics drug interaction is not very uncommon. It's not contraindicated, but it's not very uncommon. So one should be aware of that. So severe renal impairment along with diabetic ketoacidosis is a known features or side effect. Then caution in India, why? Because we are living in a tropical environment and here the chances of genital mycotic infection are very high. So DPP-4 looks better, the safest class as far as the polypharmacy is concerned, and probably a year ago there is a different efficacy in different Asian population. Now let's look at the ugly side of the various combination. The ugly side is basically gone because most of the older molecules which have probably been banned, rosiglitazone, sulfonylurea, the older ones, they were responsible for adverse CV outcomes. So one should be very careful about one such combination, sulfonylurea with SGLT2 inhibitors, requiring careful monitoring of hypotension, especially in elderly patients and those on multiple antihypertensive medication. Just give me 1 or 2 minutes extra. So another factor is obviously kidney damage risk. Improper use of certain OHAs can lead to kidney disease or worsen the renal functions. Metformin, a known side effect, lactic acidosis, is very rare, I can tell you. And then you have to understand the eGFR before initiating or before continuing, or dose adjustments required. SGLT2 inhibitors, again, a potential acute kidney injury is known, but we hardly see those. Paradoxically, rather, they have a renoprotective effect. And sulfonylurea, hypoglycemia is a risk only when you have a bad kind of combinations. DPP-4 inhibitor mostly safe, few dose adjustment with certain DPP-4 is required. But what is more important is diabetic kidney disease prevalence is high in Indian population to the about 30 to 40% in type 2 diabetic patients, and therefore regular monitoring is essential, which may not be possible in the rural population. Second, obviously, is the ugly, which is the increased infection risk. Obviously, that is mainly associated with SGLT2 inhibitor associated infection. So whenever you have a combination with SGLT2, you should be very careful about the various risk factors outlined here: female gender, history of genital infection, poor glycemic control, poor hygiene, immunocompromise. And along with that, you actually tutor the patient whenever you are trying to initiate the SGLT2 inhibitors, that you need to have these preventive strategies in order to cut down on the infection rates. So special consideration, because we are living in a hot, humid climate, the chances of their dehydration is high and you might have more of infection. So detailed patient's education is critical. Now, we all are aware of the fact that there is a progressive nature of type 2 diabetes. So combination therapy can only delay, it cannot prevent, number one. So most of them need will intensification, you might have to go to injectables. And third one is, if you have different combinations, different pills which are combined, then obviously there will be adherence issue, number of pills increases, but if you have fixed dose combination, they are much better. So again, the cost do play an important role. So that's very important. So last but one is that you need to use the right combination on the various factors, the glycemic efficacy, comorbid condition, weight consideration, cost and access, patient's preference, hypoglycemic risk. Don't make it one pill for all or one combination for all. Always consider these factors before planning out which combination are best for those individual and how to start it, how to escalate it. Monitoring and follow-up is equally important because you have to have specific monitoring to be done with different group of drugs. So to summarize, let's look at the good part. Improves the glycemic control, reduces the microvascular complication, cardiovascular and renal benefits newer drugs, weight benefits with select combinations, delay treatment failure compared to monotherapy, and fixed dose combination definitely improves the adherence. The bad part is hypoglycemic risk with sulfonyl combinations, GI side effects, the weight gain with certain combination, drug interaction should be kept in mind, complex dosing consideration also should be avoided, and cost and accessibility issue has come down with the fixed dose combination. The ugly past, we were concerned about the cardiovascular concern. Now with those older agents going out of the basket, probably that's not a big issue, but kidney damage risk with improper use, increased infection with SGLT2 inhibitor, progressive nature of the diabetes definitely means you need an escalation. So that should be kept in mind. And lack of long-term safety data for newer combination I still awaited. So key recommendation for Indian context, friends, is consider early combination therapy with complementary mechanism. Prioritize fixed dose combinations when available to improve adherence. Account for high infection risk with SGLT2 inhibitors in our climate. Consider cost constraints and insurance coverage. Monitor more frequently than what the Western guidelines say. Thank you.